Welcome, everyone, and I appreciate your attendance here on this panel discussion, Adjusting to the New Norm in Infectious Management. My name is Jim Sabagal. I'm the head of Healthcare and Life Sciences. And to begin with, I want to just put up this legal disclaimer about the content that you're going to see later today in the discussion, questions, and presentation. So with the safe harbor statement presented for you, let me begin by setting the scene in terms of what is happening right now to hospitals. And we know things are changing, that there's a lot going on in a hospital. We know that we were just discussing just a few minutes before, hospitals are now organizing themselves to give out the COVID-19 vaccine. They're treating patients at the same time. And there's also non-COVID patients that are coming back to the hospitals. And all of this has a lot of pressure on hospitals, both from an external and an internal perspective. Patients are expecting more. They want shorter stays. The whole idea of additional regulations due to COVID is causing constraints, if you will, on the hospital staff to provide all the necessary information in terms of reporting back to the regulators. Internally within the hospitals, this whole idea of financing healthcare and putting pressure on hospitals to find ways to improve the quality of care and at the same time make it more affordable. So this panel discussion comes at a really critical time. And with that, I want to introduce to you Dr. Craig Steiner. Dr. Steiner is the CEO of our partner company, AI Health Insights. This is a clinician-led technology company, and they're on their way to transform the way infections are managed in acute care hospitals. With that, Craig, I wanted to turn it over to you and our distinguished panel of speakers. Craig?
Thanks, Jim. And more importantly, thank you everybody for participating, especially in this times where you're trying to wrap up your year. We really appreciate your time. So this is all about infection management. And infection management has been a sleepy topic in the domain of experts and acute care hospitals and regulatory agencies, all until this pandemic. And this pandemic amplified the problems both internally and externally that Jim brought up. For example, in California, COVID testing, we're getting positive results about 4 or 5% of the time. Now they're over 10%. The number of hospitalizations in California has gone up over 70% in the last 2 weeks. The ICUs have been filling to the point that the ICU capacity is below 2% in Southern California. Now that reduction in capacity in California is due to more admissions, but it's also due to staff shortages. And because of this, the system is stressed, the healthcare system. The staff is stressed, and there's multiple stakeholders are involved and have been involved in this issue for quite some time. So in this discussion of COVID-19 and experts' view on the new normal on infection management, we've brought together a panel of experts who represent 4 distinct and critically important groups in managing this. So let me introduce them. First, James Curtis. He is the Associate Director of the Pharmacy at Penn Medicine, Chester County. James has been intimately involved in rounds in the ICU and managing acute care. He also is involved in his staffing and clinical decisions on escalating and de-escalating care. Kevin Soti. Kevin Soti is the Chief of the Medical Staff at Penn Medicine, Chester County. He's also the Director of Internal Medicine. He's a hospitalist and runs the hospitals who control a great percentage of the population at the hospital. He has both direct patient care duties and administrative duties. Tim McClung. Tim is from the Connecticut Hospital Association. He's intimately involved on a daily basis with both the quality assurance, quality management, and the infection prevention side of this topic. And Jeff Weiss is the CFO of Bryn Mawr Hospital, of Mainline Hospital Organization. Bryn Mawr has been known for decades as a leading hospital in both patient care and patient satisfaction. They have been a model institution, and because of that, we're very happy to have them. Thank you, James, Kevin, Tim, and Jeff for joining us. So what I'd like to do now is kind of dive into how COVID has changed things. Let's start with you, James. You've been dealing with infection challenges before this pandemic, and what are the challenges for pharmacists during COVID-19 and other infections, and how has this challenge changed?
Sure. Well, thank you, Craig, and thank you again, everyone, for attending today. I would like to just discuss from the pharmacist perspective and how this really impacts our workflow with our clinical folks. Pharmacy is really ingrained with antimicrobial stewardship. And since the beginning of the pandemic, what we found is that it's a lot of the same people doing the same jobs. And so these same clinical folks with these infectious disease expertise, they're the ones that are being pulled aside to figure out, how do we treat COVID? How do we adhere to these guidelines? How do we develop these guidelines? And so there's a lot of new therapies, a lot of new information that's being thrown at us all the time. With the first go around with COVID back, in March, we were really just scrambling to figure out, how are we going to approach this? How do we cohort people? How do we organize treatment? And so what we found was that business as usual doesn't go away. I mean, you still have multi-drug resistant organisms, you still have resistant pseudomonal isolates, you still have surgical site infections, et cetera. And so what we found was that while our attention is, and rightfully so, focused on COVID and patients, we were really ignoring a lot of our long-term standard responsibilities. And so for us, we have noticed that over time, since we've been living in the COVID world, items like our surgical site infections have worsened. So we have increased that. And so what we've found is that our ability to actually go back and monitor some of these perioperative antibiotics, or go back and analyze some of this data, has been very, very limited, because it's all the same folks. There's also new therapies now that have to be ingrained into our workflow. So, for example, remdesivir is one of the mainstays of therapy, but now there's a lot of specific use criteria around that. And so the pharmacists that would typically be monitoring these infections and these antibiotics are now monitoring remdesivir usage, because it is an expensive therapy. It is a niche use, and the guidelines for how to use it and for how long are constantly changing. So it has been quite challenging from that perspective.
Great, James. Thanks a lot on that. I'm sure there's more to it, but trying to highlight those acute issues have been a nice way to introduce your role in all of this. Kevin, I'm going to jump to you, staying on the clinical side. As many of your patients are placed on antibiotics, does your current workflow and documentation, the requirements that you have to deal with, impede your ability to care for these patients? What have you seen with COVID?
Yeah, I'd like to second James's kind of comments that this is a team sport. We do have to work with each other. And often what we found more now with COVID than prior years, that a lot of the workflows, especially in EMRs, they're very clunky. It's hard to access actionable data, with a push of a button, even when we're spending all this money on expensive electronic medical records and health records. We do depend on others. I depend on my pharmacy folks, the infectious disease folks, to let me know what the sensitivities are, how those are changing in the community. So I think those have always been a problem, but what we've learned during the COVID era, the rate of change and is just so much faster than before. Not only treating the usual infections, which has become much harder because of all the things you said, our capacity constraints and all the COVID patients coming in. But even treatment for COVID, for example, it was changing almost daily and weekly, and it's still kind of continuing to change. And having that actionable kind of data to the frontline clinicians and making it easily accessible is sort of what we struggle with day in and day out.
Yeah, Kevin. Yeah, I could imagine when you're trying to manage all those patients on the different floors, running with all the admissions coming in from the emergency room, following up for the next 48 to 72 hours, getting granular data so you can make clinical decisions, deciding whether patients need to be isolated or not. All of that is key in affecting your workflow on a daily basis. Tim, what are some of the challenges that have arisen from COVID-19 that affected the processes and the staff members of the infection prevention and quality management teams?
Morning. Good morning, everyone, and thank you for the opportunity to be with you today. Change is constant, and we're finding that this has a direct impact specifically on staffing among the quality and the infection preventionist professionals. There are a lot of things at play. For example, after the first wave, there were a lot of retirements that went on, so creating a staffing stress on staffing. Staff are tired. They are stressed out, very concerned about how they're going to manage. They're all working to their overall emergency operations plan, which has its own procedures and methods that they have to follow. Think of the environmental changes that are required. We have one hospital that created a patient movement corridor strictly devoted to the movement of COVID patients, and think of the infection control and quality issues associated with maintaining that space, the integrity of that space. In addition, this is going to have a direct impact on overall antimicrobial stewardship programs, particularly related to auditing and reporting, et cetera, that the quality and the infection practitioner folks are involved with on a daily basis, a regular basis. And in addition, any kind of performance improvement, say associated with central line infections or catheter-associated urinary tract infections that quality and infection preventionists may have been working on, has in many cases been stalled because of redeployment. Many of these departments, particularly I'm thinking in quality, are staffed by former clinical people who may be redeployed because of staffing needs due to the rapid increase in patient volume. In terms of their performance improvement activities, they may be curtailed a little bit because of the patient volume.
Yeah, so Tim, it sounds like the redeployment of personnel to this emergency system that has basically happened over the last 6 months or so, along with the loss of some staff due to retirement and stress, have curtailed some of the important metrics that have to be reported to the NHSN, reported to the CDC, any state agencies, any other reporting that could affect not only clinical care, hospital-associated infections, acquired infections, readmissions because things are not being addressed on an acute basis early in their progression, and could have effects on the revenue side and on the patient care side. So let me just jump on the revenue side to Jeff. So the healthcare system, Jeff, has been stressed with high costs, and COVID, I know, has caused financial stress in many of these hospitals and hospital systems, especially some of the smaller ones outside of the urban areas in the big cities. Can you give some more clarity on how COVID has amplified this?
Sure. And thank you, Craig. That's a good way to phrase it. Yeah, I mean, I have not seen this type of economic upending situation in my entire career. I mean, it's very, very unique, seismic things that are happening right now. And yes, pressure both on the cost side and the revenue side. We're getting it from both angles. On the cost side, we have things like, and Tim touched on this, we have things like furloughs. So we have people that in our clinician staffs that actually were exposed or have COVID. So they're taking time off, and we've been generous about continuing their compensation. And now as we enter the second wave of this thing, we're incurring expenses with vaccination of our staff. So you have it on that side for staffing. On the cost side further, for providing care, we have things like length of stay that are getting impacted, particularly in the ICUs. The length of stay of COVID patients is typically about twice what it might be for other ICU conditions, maybe up to 2 weeks. So we've got that. On the revenue side, and it's an interesting story because it's sort of a tale of two cities on this one, in the sense that, yes, we have pinch points in our ICUs with throughput and capacity, as well as some of our higher level telemetry units that can manage COVID patients. But on the other hand, what we're seeing, and actually in this lull that we've had in terms of the first wave and now going into the second, is that we have seen a significant disappearance of, and I'll call it volumes, visits through our emergency room that just has not come back. And also low acuity stays that typically would go into a patient status called observation. It's really an inpatient stay, but it gets classified as observation. It's sort of a watchful waiting while you're in the bed. So those are low acuity by definition. So those things have gone away. And, we're not quite sure. There's lots of factors involved in that. It could be medical distancing, as they call it. People are not coming in on certain conditions like chest pains and potential strokes. There was an article a couple of weeks ago in the New York Times called "Where Have All the Heart Attacks and Strokes Gone?" This is from a finance perspective, because what we fully expect is that these patients that have been doing their watchful waiting at home will show up eventually back at the hospitals in more dire circumstances. So we're kind of bracing for that. And the other thing that might be going on for lesser acute things that people, and this is a disruption issue to our industry that finally might be taking hold, is telehealth, urgent care. So we believe that there's been a shift to that, because quite frankly, you don't always need to go to the emergency room for things. So we think that's going on. So it might be a tipping point in this consumerism area. But again, it's all costing the hospital. On one hand, like I said, throughput's an issue on high acuity, and then the low acuity is not coming in for revenue purposes. I can tell you to also impact us financially in terms of, and this is where this tool really comes into play, is that our quality, and that quality comes back to hospital-acquired infections, episodic care. Are we taking care of people in the right way with the right drugs in the right length of time, all such that they don't come back and readmit? Because all of those issues are things that are inside of many pay-for-performance programs. CMS, the big one is value-based purchasing. That absolutely has a lot to do with hospital-acquired infections, length of stay, overall episodic cost of care. And when I say cost of care from a CMS standpoint, they're really talking about how much they pay us. They're not really concerned about what our costs are. They are more concerned on how much they paid us. So it's incumbent upon us to manage that revenue that we get, because I can also say that the revenue we get now is all very much case-based. So it doesn't matter if someone's here for 4 days or 40, we're going to get the same case payment from these payers. Now, I will back up and talk about, what kind of financial relief the industry has received, and all health systems for that matter, from the CARES Act. So that's the Coronavirus Relief Act, that basically put out there for providers. There's other parts of that, of course, for, support for other kinds of businesses and loans and so forth. But we have all received some pretty good tranches of revenue, of support money for that in two ways. One of them is just pure stimulus, and the other one is something called advanced payments. Now, the advanced payments are based on your proportional amount of your Medicare business that you've had. The insidious part about it is the fact that it needs to be paid back. It's just a delay in revenue. So the assumption there is that there'll be some pent up demand. People will come back. We're not seeing that yet. And I'll tell you, there's providers, health systems out there that were really not prepared for this because, and really it all comes down to cash, right? How much cash reserves and cash on your balance sheet you have. So a lot of hospitals and systems have had to utilize their cash on hand to get through this time period, even with that stimulus payments. And if they have to give it back, it's just not there to give. So it'll be interesting in the coming year and months to see how that continues to play out.
Yeah, Jeff, that's real granular. I appreciate all the details on that. And I see that, you know, the value-based purchasing, all the Medicare penalties, you know, they get updated each year. They have, I think, delayed some of the required reporting, but that will come back. And these penalties, which have been increased, as I mentioned, really will affect you in 6 months to a year and the following year. It's not something you're seeing now because it's a retrospective review. So those could even magnify the effects financially on the institution. Using that as an opportunity, I just want to jump back to the beginning of the panel and go back to James, Kevin, and Tim and say, look, you know, you've got these financial pressures. What can we do? What can we automate? What would be a magic wand that would solve your individual problems that would not only help patient care, but also help Jeff's concerns about value-based purchasing and other financial metrics that are key, reducing length of stay, reducing HAIs, getting early observation. So I guess my question to you, James, is if you had a magic wand, what would you do so that you could optimize your patient care and not be distracted or whatever you need?
Yeah, and you know, I think going back to the staff with that specialized knowledge base with infectious diseases and antimicrobial stewardship, they are such a limited, scarce resource that are being pulled every direction now. So I think if I had a magic wand, it would be to enable other clinicians to be able to perform some of those tasks that would typically be only achievable by those folks with that specific knowledge base, but give them the tools to allow them to do some of those interventions seamlessly and quickly, and to get all of that information in a singular place so they can do more with their time and be able to look at some of these therapies. So for example, you know, one thing that should be simple, but it's not, is antimicrobial de-escalation. So we've struggled with it for years, right? And so a lot of it is that it's not necessarily simple to count how many days I've been on an antibiotic. It started, it stopped, the dose changes, the dose decreases, I add an agent, I change an agent. So there's a lot of different data fields. And so unless you're very savvy or unless you're very accustomed to thumbing to all these different areas and looking at all these different orders, it's not intuitive, right? So I think you have to make it easy for your average clinician to be able to look at these things and to have the time to do it, because, you know, as an infectious disease pharmacist, that's your bread and butter. That's what you do. But, you know, if you want somebody, like I'm looking at Dr. Sodi, so, you know, somebody like a hospitalist or one of his advanced practice providers, I think really having, you know, enabling those types of folks to do the same sort of interventions is really what's required now, because those folks with that specialized knowledge base, I mean, their heads, they're involved in other things, right? So looking at, you know, now we're evaluating monoclonal antibody therapies as outpatients for some of these COVID positive patients to help prevent hospitalization. So our infectious disease experts are really involved in that realm and much so distracted from I'll call them just the normal hospital duties.
Yeah, that was great, James. Yeah. So Kevin, James just put more work on you. I assume you need some help because you're already talking about clunky solutions. What can we do? What would your magic wand do? How would that solve things?
Hey, Kevin gives me a lot of work anyway, so I'll give it right back to him. It's fine.
Now, I think a couple of things. I think technology has been moving all of us to empowering end users. I think in healthcare, that has not been necessarily the case in a lot of instances. And I think that's what James is referring to. And I think that's what we need to be inspiring to do. And then to Jeff's point, we really are moving away from fee for service to this value-based purchasing with the bundle payments. And that is not going to stop. I'm just going to pivot a little bit to the fact that I think Tim said that 50 to 60% of our providers are at risk of burnout, at high risk of burnout. And I think health industry and all the healthcare delivery places need to recognize one of the most, their staff is very valuable. And there is this thing that and it's not just the providers, nursing, everyone, they've been running a marathon and a sprint together during this time. And as we move towards these value-based purchasing, there's a lot of pressure on quality indicators and protocols that we have to meet. So I just want to put that in perspective. So now you have all this pressure on providers that are already very strained, and we have to perform at a higher level. So what we need to do is, what I want is to have elegant solutions that the data is seamless in front of me. It's making me not work for the data, but it's actually working for me. It has to be integrated. So I want to just click on the patient and see what I need to see very quickly and not have to go to 50 different platforms and talk to 50 different people. And it also has to be aligned with my sort of operational workflow, how I do things. So when I'm bringing a patient in the emergency room, and I want it to be right in how I do my workflow. I think those are things that are on my wish list, and I do lose sleep that as we make more and more work for the providers, because there are those, Jeff is under a lot of strain with the value-based purchasing, and they have to, the revenue is going to be put in differently. But putting that pressure on the providers, we have to give them the tools so they can act and use those behavioral nudges so I can see and make it easy for me to make the right decisions for antibiotics. If I'm not choosing the right antibiotics, the length of stay is going to be higher, readmission rates will be higher. But if I'm choosing the right thing, one, I'm meeting those quality indicators, and it's basically the value for the patient. The patient's going to be healthier. So those are the things that I want, and I think that I want on my wish list for Christmas.
Beautiful. That was beautiful. Tim, it sounds like a lot of reporting and people have left, staff have left. What would make your world better?
Certainly, I just want to capitalize on some of the comments that have been made about infection management IT. I think there's a lot of meat there. As been stated already, I'm supporting the best antibiotic selection process for an optimal outcome as determined by the internal antibiotic or antimicrobial stewardship program is going to yield better patient healing or outcomes, right? And we all want that. And also a more efficient use of very limited resources. And this is also going to lead to a positive financial impact through the use of appropriate drugs for the appropriate duration during the patient's stay. And in addition, a potential reduction in length of stay due to the appropriate antibiotic selection and utilization from the get-go. Potentially reduced readmission rates with an appropriate antibiotic selection use during the patient's stay and as prescribed at discharge. So a technology that supports a high reliability approach to antibiotic management, built-in safety and opportunities for provider and education and feedback, I think is going to be vital.
Okay. So Jeff, I think you've gotten 3 points of view who are out there to help support the finances of the hospital and are out there to focus on the patient's care and patient's outcome. You went into a lot of detail. Are there any points that you'd like to bring up with your magic wand that would solve some of your problems?
Sure. And, you know, all the above, you know, and it's very clear, way more so than even a few years ago, that the collaboration between administration and the clinical staff is just so critical. You know, when we go to this value-based care, we're talking about episodic care, we're talking about the private physician, PCP, referral to the hospital, then the hospitalist taking care of the patient and with specialist support. And then the discharge, where are people going? Are they going to a skilled nursing facility? Are they going home or home health care? All that needs to be coordinated. And when those things fall in place, usually 99% of the time, the quality and the financial pieces will fall into place. I mean, with value-based care, there is just zero room to have a readmission. If we have a readmission, that's double the hospital stay. Even if the payer, CMS or the commercial payers, will even pay it to start with. And the one thing I see as just extremely critical to this is the EMR connectivity in that episode. And to the extent that that's there, and to have tools that are integrated with an EMR, it's just perfect. Because I don't want to speak too much for Kevin and Dr. Sodi here. You know, if it's not in the EMR, it's not going to be top of mind as much to physicians. I mean, the burden of an EMR is incredible. And to have a system, though, that can prompt them, hey, did you remember this? What about that? Is there a suggestion that it can make about a better care path, a better choice? You know, some of that, I'll just call it artificial intelligence. And, you know, at the end of the day, the clinician, the human, is every bit as important as a technology can assist. But it's good to have it there. And like I said, it all falls into place when those things are working well.
Wow. Really good discussion. So it sounds like we've kind of hit on how COVID's affected infection management, which has come from a sleepy, expert-driven subject to a front-page topic. We've really drilled down on some of the issues, both clinically and financially, and from a reporting point of view and quality. Let's jump over to Jim. Jim?
Yeah, I have to, first of all, thank the panel, because I think a lot of the points that you brought up, and there are some questions that have come up here as a result of this, I think it is rather important. I know, Craig, working with you and your team, you have a product called GermSoft, which is primarily meant to address some of these issues. What I heard so far has a lot to do with integration. Certainly, there's a lot of stress going on with the staff. There's a number of things happening in the hospitals. There is the additional reporting that's being required, and that actually ties back into the financial aspects of things. And so when you start to look at a particular solution, and again, it keeps coming back to GermSoft in my mind, this is also being reinforced by the discussions that we've had as a company with various hospitals, all looking for the same thing. The issue could be that every one of the panelists has a different EMR system. And we can't basically have a solution that is going to address every single one of the nuances within the solutions. Some of the EMRs can provide the reporting, but in many cases they fall short. And so what I see from a GermSoft perspective is largely that agnostic, you know, I don't care which EMR I'm going to connect to. Our company deals not only with EMRs in the United States, but also globally. So we're able to kind of use that product almost anywhere. So I just saw there was a question here regarding integration, which I think we talked about here for a second. There is some other questions that have popped up, and I think you've already addressed some of them, because what you ask for, what you're wishing for, is what GermSoft does provide. So one of the questions, what if you had GermSoft available to you, what's the biggest need in terms of infection management? If you could summarize it, right? Like, I have this product, I can get over the technical aspects of integrating that into my particular solution. So let me pose that to the panel, because that's one of the questions that was brought up. And I'm going to work in the question on integration in another question. So let's address that one in particular. If you have that product, how does it improve on the infection management side?
Yeah, I think that one really should go to James, because he's the focus of antimicrobial stewardship. James, there's a lot you could talk about. You want to take it from here?
Yeah, so there's a lot of great features. I think as a end user clinician, one of the selling points in my mind is that it's easy to access. It's not a discrete login. A lot of these antimicrobial stewardship systems, they're typically a separate web-based login. So even simply accessing the site, sometimes through your VPN at your hospital, it's cumbersome, and it's so to get people to actually use it is difficult, challenging. So I think the integration into your existing EMR is just extremely important. In terms of specific features, one of my favorite and that I find just incredibly useful is the ability to generate an antibiogram ad hoc with real-time data. So typically your antibiogram is compiled annually, so you're usually working with year-old data anyways. So I think the ability to have an end-user clinician really get granular with what specific unit. Am I looking at ICU patients, non-ICU patients? And then also based on the culture type, am I looking at urine isolates? Am I looking at non-urine isolates? Am I looking only at bloods? So the ability to get that type of data at your fingertips in a single report is just incredibly valuable. So it really helps you get the most correct antibiotic. Ago, it would have been a different choice. So empirically, when selecting empiric antibiotics, that's an incredibly valuable tool. So certainly one of my favorite features.
So one of the questions that was raised, Craig and James, is this whole ability to integrate that tool into a physician's workflow. Can you, and again, forgive me, I'm not a physician, so I'm not in that position of actually executing with that. But let me talk to you folks. I mean, obviously, you're doing this on a daily basis. How does that workflow happen? Can you just describe it for us? Tell us, is this an easy thing or a different thing? My final point before you take over here is that a lot of the competitive solutions I've seen sit outside the EMR. So that means I have to go to one screen then another. So in simple terms, it's like having two computers, and I don't really think I have the time for that. Does that make sense? I mean, let's see if we can address that, because that was a question that came from the audience.
Maybe I can.
I think this.
Go ahead.
Yeah, so I think the perfect workflow would be, you see the infection, the culture, you'll see the sensitivities, and you have your local antibiogram. How is this bug, what are the sensitivities or resistance patterns in your neighborhood? I want it to be actionable to the fact that I'm not looking at Johns Hopkins antibiogram, but my local here, according to my data. And I want it to be right in front of me. And that's sort of what I think we think about the workflow of physicians. So I want to be able to see what was the bug, where was it, and what is the right approach to treat it? Which antibiotics do I choose according to the local sensitivities to that? That is kind of the holy grail in my world, treating the patients, to be able to go one place, find it, and it sort of nudging me to use the right antibiotics, not the antibiotics that the local rep was pushing last week.
And then, Kevin, I wanted to comment as well that so GermSoft can also incorporate your hospital or your health system's antibiotic formulary. And so that's also, in terms of formulary compliance and really guiding clinicians, maybe I know I should use a carbapenem, but which one am I using now? Because there's a lot of new agents that have entered the market, specifically the beta-lactamase, and beta-lactam, beta-lactamase inhibitor combinations, all of which are somewhat nuanced to use. So I think the ability to incorporate that is really important as well.
Yeah. Another question that came up, and I think, Tim, this goes back to your comment about changes occurring at a rapid pace. External agency requirements, they just show up, right? We don't plan for them. Hospital has to deal with that. And I think Jeff had mentioned earlier about the EMRs, and basically you get what you get in that EMR. If there's nothing wrong with it, we would never tell a hospital, hey, to get that feature, replace that with this. That's not going to happen. How is that addressed, if you will, with GermSoft? I mean, as new requirements show up, you obviously have to address them. And I think we've been talking about data.
Right. And thank you. The quality and the infection preventionist community is going to be looking like what are our outcomes? We want to make sure we're getting great patient outcomes, and an application that is easy to use by prescribers and will yield better compliance. And we have easier access to the data and on-demand reporting for information dissemination, education. That's great. Ease of integration with the existing EMR. We've all been around long enough to see where that doesn't work and what a burden that is on providers. And the ability to provide reports that identify trends and patterns in ordering and antibiotic utilization per provider is definitely a benefit.
Oh, terrific. The question that comes to mind, I started this whole thing off by saying, the financing healthcare gets to be more difficult. The pressure on hospitals is to provide high quality care at an affordable price. So another question has to do with the ability for the solution to reduce costs and improve payer reimbursement, because in this country, that's kind of a source of financing, if you want to think of it that way. So how about that in terms of doing that? Jeff, I think you're still on mute. There you go.
Sorry. Yeah, a couple angles on that. The biggest one is again, back to this episodic care and pay for performance. None of the payers, that being a CMS or a commercial payer like a Blue Cross or United, none of them are doing anything with an intention of paying us more. So, unfortunately, we're in a world of penalty avoidance and I would say making up the perhaps reduced payments in volume in more patients. And no better way to do that than to show your value and your quality and have that get disseminated. And the thing I really like about, and this is what Kevin was saying, Dr. Sodi here, about, it can't be any more real time than how he described in terms of how GermSoft would be integrated. I mean, with value-based purchasing, there are significant payment penalties for that. The problem is that the feedback loop is literally, more than a year. We can't react or know about it for a year down the road. Sounds like with this tool, I mean, not only do the physicians have it at their fingertips, but we're going to have reports on it that are much more current to deal with. So to get back to the payers though, I mean, how can we increase our payments? Well, one way to do it is to demonstrate the quality and value. One of the big things going on these days is plan design from an employer and payer perspective to steer patients vis-a-vis their plan designs to high quality, lower cost facilities. So, I mean, this is just one way to demonstrate that, hey, our hospital ought to be one of your preferred providers that your plan design provides that incentive to utilize. So again, and to do so, there's better payments involved in that kind of track.
Okay. Okay. Let's take a look here and see if there's other questions here. There was a question that was brought up about protocols. I'm probably not the, probably the right person to answer that kind of thing, but how is all this related to protocols being asked for from the hospitals and its connection to the ability for the product to provide that?
Yeah, let me give that to Kevin, but let me tee him up a little bit. Kevin, when you're on that GermSoft tab on an individual patient, there's a space toward the bottom middle of the section on the right where it has all the information on current sensitivities and resistance in a clear one-click manner, and the protocols that are developed within the hospital are usually right there. So in your institution, are you finding that protocols are put together, and are they updated on a routine basis, and are they distributed, and are they easily accessible so that the whole clinical staff knows what's going on so that care is done in the appropriate manner?
Yeah, thanks for the question. That's a very good question. I'll go back to the rate of change of how we're doing things, even without COVID. For example, I'm just going to give you an example for the sepsis CMS bundle. So we have to do things very methodically in order to not fall out of that, which has significant payment consequences if we do fail. The blood culture must be done, the antibiotics must be given, appropriate antibiotics must be given within a short period of a window period. COVID, the algorithms for the treatments. It is very hard to be able for any, we have a big institution, a health system here, but all the health systems, it's very hard to implement that protocol where the frontline provider can access it very easily in most EMRs. It's just, one of the biggest problems has been communication. How do you know something, how do you get it to the frontline clinicians that they can act on it? So I think this solution to be able to add something fairly quickly, some protocols are there for years, we ability to have that where I am looking at that data and I can look at the protocol and make the right, going back to that, all the behavioral economic stuff and nudging to do the right thing. I think it's very important. And as the rate of change continues to just increase, that is something that we need to figure out how to do. And it looks like the solution here with GermSoft, as you explained, Craig, it's a wonderful one that I don't have to click to go to another site and look up, the algorithm, the local algorithm, how we've decided to do it is right there. And I can see it to do the right thing.
And I think that really helps with antimicrobial stewardship too. So, in the example of community-acquired pneumonias, and let's say you're starting azithromycin and ceftriaxone, but I need you to stop one of the antibiotics after 24 hours, 48 hours. So I think assurance of compliance, with some of those types of therapeutics, it's really important to have those protocols just readily accessible. So your end user, your average clinician knows what to do. And can help us meet our goal metrics.
So not just as a question that was asked, but in the experiences of talking to other hospitals, at the end of the day, it's one more technology they have to make a decision on. How quickly do you believe, given what we talked about so far within the past hour, with all the different pressures that the hospitals are gaining, there is this call to action in terms of, if I put this in, how is it going to impact, my ability to provide that affordable health care? How is this going to impact that cost? Do we have some idea for how quickly we can assume those benefits? I mean, everything we talked about, it just sounds like GermSoft can provide that. It just, how quickly would that happen? How would it occur? Because again, there's some folks that'll see this and say, okay, everything sounds really good. What will it mean to me at the bottom line for my particular hospital?
So let me jump in on that one. That's more of a technology question. And what's presently the major points that have been brought up on the clinical side is that having to go to another login, having to use a VPN, having to have something that is more related to documentation and not working with the workflow of the clinicians. This is what these are the bottlenecks, the hurdles that need to be overcome. So we expect GermSoft to provide value within a week, really. And there's different timelines for different parts of the value. But the reason why it's so quick is that there's no change in the EMR. There's no additional technology to learn. There's no cognitive decline because you're focused on clicking and how to look on what part of the screen to go where you want to go. It's just working, and it just slips in. It has the same user interface as your EHR, your EMR, so that the clinical use of it should be within days. If Kevin is looking at patients with a UTI, he can click on that particular patient, click on the tab that would be relevant, would be the GermSoft tab, and he would have all that functionality that he can have action upon within 30 to 60 seconds. But there's no learning curve because it's the same user interface. It's automatic API calls, automatic calls of the data, so the information's already populated by the time he clicks onto that site.
Okay. Well, good. I think that's it from a question perspective. Craig and panelists, is there any other closing remarks you'd like to have as we look to wrap up this session?
From my standpoint, I think that, time is one of the most precious gifts that we can give back to clinicians, particularly now, right? So a strong IT solution that's developed by and for clinicians is going to improve user buy-in through easy access. These are already been mentioned, minimum number of clicks, providing information for the appropriate choice of antibiotic, a visually easy to read layout, and that meets compliance it needs seamlessly is going to be a great point.
Yeah, from my point of view, COVID has really amplified the effects on our healthcare. Technology is always going to change. There's always going to be movement from manual reporting, manual activity to automatic reporting, automatic activity. The goal here is to automate in such a way that the clinicians and the stakeholders in the hospitals can focus on their primary goal, whether it's finances, whether it's reporting and quality metrics, whether it's clinical sides. These are their roles. This is their mission on a daily basis. And the technology needs to be done in such a way that it fits with the clinicians and with the stakeholders' use of the data. The first generation, for lack of a better word, of electronic health records were wonderful in taking physicians' writings and making it legible, accessing certain information, but they were mostly for billing. And they have been shown to be extremely good at that. But it's not clinician-led. And to have something that automates, works with the workflow of the teams that are needed, does the reporting, and adds business value along with actionable data in a simple manner, that's what we aim for. The reason for this webinar was not only to understand GermSoft, it's also to understand the clinical and the business stresses that are going on in healthcare and the need to solve these problems. Thank you very much, Jim, for hosting this, and really appreciate it.
And thank you to the panel. Let me just pop this last particular slide up here. I really do appreciate it. I hope the audience will get a lot of value here. So in closing, if you have further questions with this, let me see if this is not, okay, hold on a second. Here we go. So if you have further questions, would like to see a demo of the solution, you have Craig's email address here. so that if you have some interest in GermSoft, and based on some of the things that we talked about today, that would be good. For the attendees, we appreciate you being here. Thank you for your attention. We'll be sending you a survey. If you could provide some feedback, that would be most appreciated. And for those who were not able to, or basically register, but weren't able to make the session, and that happens, we will be providing a link to a recording so that you can see the entire panelist discussion that we had here. So on behalf of AI Health Insights and T-Systems, I want to thank you very much for your attention. I appreciate everything. Please stay safe. Have a great holiday, and be well, everyone. Thank you very much. I appreciate it.